Good afternoon, everybody. Thank you very much, Professor Abdullah and Professor Giuseppe, and I'm honored to be here. This is our 5th or 6th time. I always love it when Professor Abdullah invites me. It's a mixture of feeling. I love it, but I also get stressed out because he always hands me a huge topic and gives me 10 minutes. Hopefully, نبحبحها شوية السنة القادمة. My topic is to talk briefly about the aftermath of TAVI, and it's good to understand that we all know that TAVI is everybody talks about TAVI, but the problem doesn't end by putting the valve. I have no disclosure. These are the presentation outlines. We will hopefully briefly identify the predictors, understand the spectrum, and examine in short and long-term consequences and review some contemporary strategic algorithms. Why is this a problem? Because the correlation, two reasons. One, because the correlation between the valve, where it sits, and the conduction system, that's your anatomy class. And this has two layers, has a direct and has an indirect. So sometimes the valve frame doesn't just directly touch the conduction system, but causes edema, and edema pushes on the conduction system. The second reason is most of these people are, as you know, elderly or in the elderly-ish group, now with a low risk, where you're heading in the 60s. Still, they have a pre-existing conduction system abnormalities, which makes it high risk. As you can see, the incidence is quite high. There are really a lot of reasons that play a role, as I said, factors related to patient, procedure, device, but it's more important to understand that the risk continues beyond the discharge. And if there's one message I can get you all to understand today is this message. Incidences are quite high, and this is seen when both FDA-approved devices that we're familiar with, but there is a slight increase of pacemaker with the core valve, self-expandable or self-expandable generally versus the balloon expandable. These two diagrams depicts both the pacemaker indication, incidence, and the left bundle, which becomes a factor or predictor for pacemaker. As you can see, there are elements of, in the blue is a core valve, they're kind of higher than the red, which is the Edwards valve. And that kind of parallels the same way with the left bundle branch. The green is the portico valve, and you can see the yellow is the accurate. But both the left bundle and pacemaker kind of run the same pathway. There are trends of pacemaker incidences depending on really some of the sites. But there has been good news. There has been, in the last 6-7 years, a dramatic drop in the pacemaker rates down to 9.7 on average. But it is a bit inflated, if you take. But this is all comers. There's a wide variation across the sites. Surprisingly, there's no volume-related outcomes, which I question because I think it is a learning curve. And the reason you see the decline is because we learn as we go along, and there is a lot of learning curves. So volume does play a role, although in this study it did not. Clinical implication. This is kind of ties it up to our topic today. Pacemaker is bad. Yes, it saves lives, but it has a long term, and it was very eloquently described by my colleagues earlier in the talk. This is data from the self-expandable core valve. You can see with pacemaker, without pacemaker, all-cause mortality is higher, up to 5 years. And if you look at the left bundle, which is a result of what you see with pacemaker, they kind of follow the same trend. And mortality is higher, all-cause mortality, not mortality cardiac, but there's certainly more heart failure hospitalization with people who receive pacemaker. So you can see on the right side of the forest plot curve, the dots accumulate, which favors really no pacemaker. But certainly there's an increased cardiac mortality, increased hospitalization, and an increase in mortality all cause. There are two predictors that we can learn as we go along after we deploy the valve. If there's a new left bundle, that's a red flag. If there's a high-grade AV block, that's a red flag. Now, left bundle incidences happens about 3 to 5%. And when they pull data from Partner 2 trial and the S3I trial, these are the SAPIEN valves, you can see that the left bundle, as we said earlier, at discharge and no left bundle, there's all-cause mortality increases. Pacemaker implantation, naturally, because it's a strong predictor, increases, and rehospitalization increases. But it's also important to identify the persistent versus the non-persistent. And the separation between the two is the 24 hours. So if you have a left bundle, we kind of watch it. We may leave a pacemaker in place, but we're going to watch it because majority of those do subside the next day, and that's good news. But those who persist is the one that we need to closely monitor. And this has been shown that you can see in the almost everybody in the patients who developed left bundle, obviously all of them had it, but after discharge, 50% of them or 40% of them did not have it. And they looked at this in a quick study that 143 patients of all left bundles and on the same day, and then they followed them up at post-op day 1. 50% of them resolved and 50% of them remained, and those are the ones that had a higher incidence of a high grade. But those who resolved had 0 incidence of high grade AV block or pacemaker indication. What about persistent? Now, this is another very important message. Persistent causes bradycardia. It could cause some slowing down in the rhythm. It is important, but it does have a high correlation with pacemaker. And when you can see that these people end up having a pacemaker or ICD if they had a low EF, that the majority of them were asymptomatic. So bradycardia may be present, but the patients may not complain. But these people should get a pacemaker if they have a high-grade AV block. What is the definition of high-grade AV block? We remember Mobitz 1, Mobitz 2, first degree, and Wenckebach. But there is a whole new definition of what we call high-grade AV block, and this is from the TAVI and the VARC definition. 3 types, either advanced second degree with 2 or more consecutive, Mobitz 2, and certainly transient or persistent complete heart block. If you develop any of these 3, this is the second red flag that I showed you earlier. What is the incidence? Well, again, just like the left bundle, there's persistent HAVP and there's delayed. And the persistent, the early one that tends to, there's early and there's delayed. The early one tends to subside, but the delayed happened about 3.7% in this study population. And there was correlation between the type of the valve. Self-expandable valve had a higher incidence of delayed HAV versus the balloon expandable. And a coexisting new left bundle obviously had a higher incidence. And if you had left bundle and a first degree AV block, that even correlated higher with the HAVV. So there is a cumulative incidence of predictors for HAV block. So in that study, particularly the predictors for HAV block, this is important that we know as we analyze our patients, that RBB baseline, we keep an eye on those patients. First degree AV block at baseline, we keep an eye on those patients, and new onset left bundle and self-expandable. Every TAVR case has to have an ECG and needs to be reviewed before the case, because that definitely highlights these patients at a different level. So pre-TAVR RBB is important. We talked about that. Also another indicator. And then this is interesting. The new technologies now, they're actually, for those who have a high risk, we tend to do RA pacing, and we identify Wenckebach. This is after the TAVR, immediately you pull the pacemaker from the RV and you put it in the RA, and you do rapid pacing. The valve is in, but you're still in the cath lab. And if you develop Wenckebach, that's a high predictor for down the road pacemaker. And if you don't, that's a very high negative predictive value, as you can see down there, about 98%, that you are in the clear. What about temporary wire? We go back and forth. This is more of a practice. What I mean by temporary, I mean extended temporary. Everybody gets a pacer during the procedure, but majority of them, we tend to pull them out after the procedure immediately. Some of them, we actually send them up to the ICU with a temporary wire sutured in place. In fact, we used to have these pacemaker that has a lock on the sheath, so the nurse doesn't inadvertently lock it. I've been 7 years in the UAE, have not found that lock sheet available yet, so I might have to go to the States and pack some and bring it home. Now, it's important, and again, there's no clear science about it, but keep in mind, pacemakers can dislodge, pacemakers can cause perforation, so it all depends on your practice. Now, it's very important that to highlight, again, this next take-home message, that 2.2% is the mortality of TAVR. About 1/3 of those die between the period of discharge and 30 days. Something is happening after they leave the hospital. albeit a third of the 2.2, but this is 629 patients in that population. So that kind of raised the possibility that there is a strong need to be more vigilant about these patients. And this brings up the, I just need maybe a minute or two, please. Brings up the MCOT concept. MCOT is the mobile cardiac telemetry, and that's been shown to have picked up about 10% of the patients that may need a pacemaker beyond that period, and has a lot of room and a lot of pull. And we do it now, but sometimes the limitation is the insurance. This is when we do the case, it allows us two things. One, identify those people, because the majority of these events tend to happen the first week. So if you cover that 1 month and give them that MCOT, you're going to capture that other 1/3 of the mortality, hopefully. But also allows early discharge, because if I'm sending the patient on the MCOT, I can send them home the next day. And I want to, there's always this Apple Watch, and I want to finalize my last slide here, that this is the algorithm we follow. Number 1, no ECG disorder, you're safe. Number 2, if you have a pre-TAVR RBB, watch those patients. Post-procedure, no change. Consider the ancillary stuff and red flag them and put them on an extended monitoring, and then send them home on MCOT. If the pre-RBB has changes, please put them on extended monitoring with the pacemaker up on the ICU, and then send them on MCOT, mobile cardiac telemetry. And then if they have a new onset, persistent left bundle, those are the ones you really want to watch very closely. And RA pacing is taking its place. I want to end this with the slide, and thank you very much for your attention.
Thank you very much.